Welcome everybody to this first international lecture promoted by the European Congenital Heart Surgeon Association and also by the Italian Cardiac Surgery Association and the Congenital Domain. We have the privilege and the honor to have with us today Jeffrey Jacobs. Professor Jeffrey Jacobs is a professor of surgery and pediatrics at the University of Florida. It is well known over the globe, for his, scientific commitment with many societies, the CHSS, the ECHSA, the World Society. He's a good friend and accepted to deliver this first international lecture. That's going to be the first of many. And the title of his lecture is The Outcomes Analysis and Quality Improvement in Pediatric and Congenital Cardiac Surgery. Jeff, the floor is yours.
Well, thank you very much, my good friend Vladimiro. This is a big honor for me. I had the privilege of training in Europe at Great Ormond Street back in the 1990s. And ever since that time, I have felt a very close tie to Europe and to the European Congenital Heart Surgeons Association. The first European Congenital Heart Surgeons Association meeting that I went to, I attended as a guest while I was a senior registrar at Great Ormond Street. And Martin Elliott brought me across the channel to a meeting in Paris in October 1995. And ever since that time, my wife and I have had the goal to attend as many ECHSA meetings as we can. It's our favorite meeting. We get to see great cities in Europe, and we get to interact and collaborate with great colleagues. And for me, to receive an invitation from Vladimiro as the president of the European Congenital Heart Surgeons Association to have the opportunity to speak on a webinar, it really is an honor and it means a lot to me. And I want to share with all of the audience how important this is to me to have the chance to give this talk. My assigned topic today is outcomes analysis and quality improvement in pediatric and congenital cardiac surgery at a webinar hosted jointly by the European Congenital Heart Surgeons Association and the Italian Society for Cardiac Surgery. And I will really focus specifically on the role that databases can play in outcomes analysis and quality improvement. The focus of this talk really is on the intersecting domains of three areas: outcomes analysis, quality improvement, and patient safety. And all three of these areas are tightly and closely interknit and related, as shown in this Venn diagram. Before I start, I want to acknowledge a few of my colleagues in the European Congenital Heart Surgeons Association. I would especially like to acknowledge Bogdan Marashevsky, who has been an academic collaborator and partner with me for 20 years in the database world. And during the decade that I was the chair of the Society of Thoracic Surgeons Congenital Heart Surgery Database, Bogdan was chair of the European Congenital Heart Surgeons Association Congenital Database. And we had the opportunity to collaborate on multiple projects and initiatives and to publish hundreds of papers together about outcomes, quality, safety. And there's really no greater academic collaborator than Bogdan, who for 20 years chaired the European database and who also for several years was president of ECHSA. I wanted to show a few pictures of Bogdan. This is Bogdan, me, Hiromi Kurosawa, and Bogdan's son, who's now actually a surgeon in Spain, at a database meeting hosted by Hiromi Kurosawa in Tokyo. At this picture, we're discussing the finer points of measuring outcomes after the arterial switch operation with a little bit of sake in our hands. And this is a picture of Bogdan with Lech Walesa, the famous leader of Poland who brought the free world to Poland. And through Bogdan, I had the honor of meeting Lech Walesa, which is another great advantage of collaborating with the great European Congenital Heart Surgeons Society. This is Bogdan's son more recently. He's a surgeon in Spain, specializing in pediatric heart surgery and tracheal surgery, and the two grandchildren of Bogdan, which I think is probably part of the reason that Bogdan has now retired to spend more time with the family. And this is Bogdan reading to his children and out on the boat and enjoying retirement. And I think everything I talk about today is a collaborative project between multiple societies, including the Society of Thoracic Surgeons and the European Congenital Heart Surgeons Association. And much of that collaboration in Europe was led by Bogdan Marashevsky. Of course, the European Congenital Heart Surgeons Association has had many leaders who have been involved in this role, and these topics have been discussed at many ECHSA meetings. These two, Jose Fragata and Chark Abels, are big leaders in the database world and have contributed tremendously. Bob Anderson, this is at an ECHSA meeting with Bob Anderson and Jose Fragata, and Bob Anderson is another European leader in the database research world. That's Jose Fragata awarding Bob Anderson an honorary degree in Portugal at an ECHSA meeting. And of course, most importantly for this talk, I would like to mention my good friend Giovanni. I had many pictures of Giovanni Stellan shown academically, clinically, in the operating theater, giving lectures, wearing a suit and tie. But of all the pictures I have of Giovanni, this is my favorite picture. This is Giovanni when he visited Florida at our program as a visiting professor, and I had the pleasure of taking him out on a wonderful day of fishing on my boat in Tampa Bay, Florida. For those who don't know, that fish is called a redfish. You can tell it's a redfish by the dot on the tail. And Giovanni has been a mentor to me, a massive, massive leader in the database world. And none of the slides I showed today would be possible without Giovanni, who is a past president of ECHSA, a past president of the World Society of Pediatric and Congenital Heart Surgery, a true leader in the database field, and who has done what most surgeons strive to do, but not all achieve. He's created a legacy in his program. So when Giovanni retired clinically, Vladimir Ovita and his team and all the surgeons that are there are following in his footsteps. And Vladimiro now leads a great program standing on the shoulders of Giovanni. So I would acknowledge Giovanni, Vladimiro, Claudia, the entire team in Padua. And I think with those pictures, it's time to start talking about some science. My talk today will have 8 parts. I'll spend 2 or 3 minutes on each part so that we have time at the end for questions and answers. These 8 parts are 8 areas that tremendous advances have been made in the last 20 years to facilitate the ability to analyze outcomes and measure quality in pediatric and congenital heart surgery. I'm mainly going to focus on the first 4 areas, and then at the end of the talk, I'll briefly mention a few points about the last 4 areas. All of these areas can actually be a topic of a 1-hour-long lecture in and of themselves, and I'm just going to try to hit a few important highlights. Note, everything I say today is published in a series of manuscripts in the Annals of Thoracic Surgery, World Journal of Pediatric and Congenital Heart Surgery, including these articles that were annual update reports of the STS database focusing on outcomes, quality, and research. Then a similar article is published every year. Here's an article from 2019, another one from 2020. Every year we publish articles about outcomes, quality, and safety as annual reports of the STS database. And all of the information I speak about today comes from these articles. In order to have a useful and meaningful database, the first step is to have agreed upon terminology, a language, a nomenclature that everyone can speak, share, and use to enter the data. The first attempt to create a standardized nomenclature in pediatric and congenital cardiac anatomy and of the congenitally malformed heart was by Maud Abbott in 1936 at McGill University. She published this Atlas of Congenital Cardiac Disease. When I was at Great Ormond Street in 1995, we started looking at the different terminology used to describe congenitally malformed hearts, not because we were interested in nomenclature in and of itself, but because we wanted to make the database work. And specifically, we wanted to make the ECHSA database work, which at that time was based in London. We looked at the most common lesion that we treat, the ventricular septal defect. And this is a picture from a textbook edited by Gus Mavroutis at Children's Memorial Hospital in Chicago that talks about the different types of ventricular septal defects using this nomenclature, 4 types of VSDs. At the same time, at Great Ormond Street, we were using a textbook by Bob Anderson that talked about all of these different types of VSDs. And at Harvard, at Boston Children's Hospital, there was a Castaneda textbook that had this picture by Richard Van Praagh talking about a whole nother set of VSDs. So in 1998, we made a computer-generated map of the ventricular septum. We put onto that map this Chicago nomenclature, this London nomenclature, this Boston nomenclature, and we created a list of terms or synonyms for ventricular septal defects to use in the STS and ECHSA-SICCH ECHSA database. We published that in April 2000 in the Annals of Thoracic Surgery, and we felt, okay, now we have a nomenclature that the world can use. Amazingly, within a few months of this publication in the Annals of Thoracic Surgery, the Association of European Pediatric Cardiology published the European Pediatric Cardiac Code in Cardiology in the Young. So in 2000, we were left with two nomenclature systems. A nomenclature system developed under the logic and thought process of Bob Anderson, and one of the logic and thought process of Richard Van Praagh, with substantial overlap. The nomenclature had started with the nomenclature from Abbott in 1936, had evolved into these two competing nomenclatures around 2000. So in 2001, at the World Congress of Pediatric Cardiology and Cardiac Surgery, we had a nomenclature summit to talk about what can we do to synthesize and normalize these two systems of nomenclature published in Cardiology in the Young and the Annals of Thoracic Surgery. This is the group of people that met at that meeting, again, back in 2001 at the World Congress. And we can see in this picture many of the database leaders that then spent the next 20 years doing database work to standardize nomenclature. Bob Anderson and Richard Van Praagh are in the center of the picture. Rodney Franklin from England, who is a big leader in this work, is in this picture, as is Martin Elliott, as is Bogdan Marashevsky, who is in this picture representing the European Congenital Heart Surgeons Association. I'm kind of very young in this picture, all the way in the back end with no gray hair. Our goals was to standardize the nomenclature, link together the systems of Van Praagh and Anderson. A big player in this picture was Paul Weinberg. Paul's no longer with us, and we miss Paul tremendously, but I should acknowledge the tremendous, massive accomplishments and contributions he made to this project, and we miss Paul greatly. All of this work that took place over 20 years led to the publication in 2001 of a standardized nomenclature system linking together the Van Praaghian and Andersonian nomenclature, linking clinical and administrative nomenclature together, and establishing the nomenclature for the International Classification of Diseases version 11. This has now all been published jointly in the World Journal of Pediatric and Congenital Heart Surgery and in Cardiology in the Young, and is now in ICD-11, and is the standardized nomenclature used in essentially every major database across the planet, including the STS database and the ECHSA database. This nomenclature has now been populated into a congenital heart atlas that has pictures of the anatomy, echocardiography, intraoperative photos, angiography, CT scans, and MRI of all of the lesions within ICD-11 IPCC nomenclature. This atlas is available for free for the world. It was released at the last World Congress of Pediatric and Congenital Heart Surgery. It can be accessed for free from the website on this page and also from the QR code on this page. So from 2001 to 2019 and 2021, we were able to create a nomenclature and terminology that we now use in these databases. This is the group in 2019 on the right. Many of the people from 2001 are in the 2019 picture. Importantly, this picture was taken at the Maud Abbott Museum, where all of this nomenclature work started almost a century later. And standing in the front, or squatting in the front, is Giovanni, who was at that point in time finishing his term as ECHSA president and was a major leader in this initiative. And another thing I'd like to point out is that it's important to me to note how the group from 2001 to 2019 became a much more diverse group, with people from more parts of the planet, more women, and more people from different cultural backgrounds. And I think that also speaks positively on the future of our professions. All of this nomenclature is available for free on the internet at this website. All of it has been published in joint publications in World Journal and Cardiology in the Young, including this publication. And we now have 318 terms in ICD-11, which is incredible considering that in ICD-6 there was 8 congenital heart terms, in ICD-9, 29 congenital heart terms, and now we have over 300 terms to describe the congenitally malformed heart, all standardized, all in ICD-11, and all in our databases. Now let's talk a little bit about the databases themselves. After one has a nomenclature system, the next step is to have a database. In the United States, we have 125 centers that perform pediatric heart surgery. In Canada, there's 8 centers that perform pediatric heart surgery. This slide shows the growth per year of the number of centers participating in the STS Congenital Heart Surgery database, documenting that by now, almost all of the centers in the United States submit data to the STS Congenital Heart Surgery database. This allows for an increasing growth of operations available for analysis. So if we look at any 4-year analytic window since the beginning of electronic data collection, in the United States, we now have almost 160,000 operations in a 4-year window to look at, analyze, and learn from. And the overall database now has over 500,000 operations. Therefore, one can say that the data in the STS database includes information from the overwhelming majority of hospitals in the United States and is truly representative of heart surgery in North America and in the United States and Canada. This is a slide from the European database showing similar growth. These two databases are the same. They use the same nomenclature, the same terminology. Changes in the database are developed and agreed upon jointly through a collaborative committee of leaders from ECHSA and the STS. The European database has shown similar growth both in the number of patients and the number of operations. The European database generates detailed reports, such as these standardized reports available on the European website that show the number of operations and various features of those operations, including bypass time, cross-clamp time, and circulatory arrest time. This shows breakdown of the data in the European database stratified by age categories: neonates, infants, children, and adults. Again, over 300,000 operations at the time that this slide was created. This shows detailed information about the different types of reports that one can access from the European Congenital Heart Surgeons Association website, just clicking on a button and activating a report looking at aggregate ECHSA data. So there's a number of wonderful databases that have now been created, including the STS database, the ECHSA database, and the database of the World Society of Pediatric and Congenital Heart Surgery. Similar databases exist also in Asia and in South America, and efforts are being made to develop an African database. All of these databases are based on the standardized nomenclature and capture fields using standardized definitions that have been agreed upon by multiple societies. Francois Lecourgaillet taught me that once one has a nomenclature system and a database, the next step is to develop tools to evaluate the complexity of the operations and the complexity of the patients that we care for. And in the surgical databases, we currently use basically two tools in order to assess the complications, assess the complexity, and assess risk. We use risk stratification and risk modeling, and I'll spend a couple of minutes talking about each one. When the Society of Thoracic Surgeons developed the risk models for adult heart surgery, for example, for coronary artery bypass grafting, those risk models were developed based on an analysis of over 50,000 operations in a given year. So a risk model could be developed for CABG, looking at 50,000 United States patients undergoing CABG in a year. Also, 80% of adult heart surgery is coronary artery bypass grafting, aortic valve replacement, mitral valve replacement, and combination of those operations. The challenge with pediatric heart surgery is that in 1 year, instead of 50,000 operations, in the United States, we have about 1,600 VSDs, 455 switches, and 700 Norwoods. And instead of a combination of 3 operations for 80% of the operations in the total database, it would require a combination of 70 operations to reach 80%. So with the 150 unique procedure codes in the STS Congenital Heart Surgery database and the ECHSA Congenital Heart Surgery database, rather than develop procedure-specific risk models, other tools were necessary to assess and adjust for risk. The tool that was initially used, and which is still used today, is risk stratification, a method of analysis where the data are divided into relatively homogeneous groups, which we call strata. And back in 2000, the initial tools for complexity stratification were the Aristotle score and the RACS score. And it's important to acknowledge that the Aristotle score was developed under the leadership of Francois Lecourgaillet within the European Congenital Heart Surgeons Association at a series of ECHSA meetings that took place across Europe in the early 2000s. At the same time, Kathy Jenkins and the Boston team developed the RACS categories, and those were the initial tools of risk stratification until the stat mortality scores were developed and published in 2010 and then recently updated in 2021. I'll talk a little about RACS and Aristotle. This is a paper that looked at all the operations in Europe and North America, looking at both RACS and Aristotle. And here what we see is 45,000 operations from the STS database divided into the 6 RACS categories. Category 5 and 6 are merged together because category 5 is small. We can see the discharge mortality gradually increasing from RACS category 1 to RACS category 5 and 6. RACS category 5 and 6 is operations like the Norwood operation. RACS category 1 is operations like ASD repair. This is the 4 levels of Aristotle, at the same time giving similar information in the same exact 45,000 operations. So around 2008 and 9, we began to realize we had enough data in the database to develop an objective way to stratify patients into categories. RACS and Aristotle were developed primarily by a group of people sitting in a room discussing what's low risk and what's high risk. They were developed by expert opinion. The stat categories were developed based on actual data in the STS database and the EACTS database. So instead of using expert opinion and subjective probability, we utilized actual objective data. The stat mortality scores and categories were developed initially in 2008 and 9 based on an analysis of 77,000 operations from Europe and from North America from the ECHSA and STS database. The statisticians will describe the methodology by saying that procedure-specific mortality rate estimates were calculated using a Bayesian model that adjusted for small denominators. An easier way to say that would be to say that the operations are sorted by increasing risk and grouped into 5 categories that were designed to minimize within category variation and maximize between category variation. We studied this in the EACTS, ECHSA, and STS database and looked at how do the stat categories work out within these 2 databases. And a lot of these, we can see a lot of the ECHSA leaders like Bogdan Marashevsky, Francois Lecourgaye, Giovanni Stellan were all part of this analysis. This is an analysis of over 111,000 operations, combined STS and ECHSA data that shows the increasing discharge mortality from stat category 1, like an atrial septal defect, to stat category 5, like the Norwood operation, based on actual objective data in the databases. This paper was published in the European Journal of Cardiothoracic Surgery back in 2012. Recently, in the last 2 years, there's a new version of the stat categories that uses identical methodology, but has enhanced adjustment utilizing more recent procedures and a more sophisticated methodology to deal with operations that have multiple procedures within the operation. I'd like to now move on from risk stratification to risk modeling. In 2014, the Society of Thoracic Surgeons published our first congenital heart surgery mortality risk model. And this risk model looked at all the variables in this table. So not only what operation was performed, which is what's in the stat categories, but also the weight of the patient, what prior surgery they had, what non-cardiac abnormalities they had, like gastroschisis or omphalocele, what chromosomal abnormalities they had, what were the preoperative factors. In other words, were they on the ventilator before surgery? Did they have a stroke before surgery? Were they on ECMO before surgery? So this information was all utilized to develop a risk model that built on the stat categories. We developed this model by looking at 52,000 operations from 86 hospitals. We then studied if we use the stat category alone, the model had a C statistic of 0.77, 0.78. A C statistic is perfect if it's number 1. So a C statistic of 1 shows perfect correlation of a model. A C statistic of 0.5 is a 50-50 correlation, like flipping a coin. Most models for medicine and surgery have a C statistic of about 0.7, 0.75. And this table shows how the C statistic improves by adding more information to our model. So the stat categories alone had this C statistic. It gets better if we add in age and weight. It gets even better if we have age, weight, and patient factors. If we now use the primary procedure instead of just the stat categories, it gets even better. And the best model, the one that we published in 2014, has primary procedure, age, weight, and all of the patient factors that I showed in the previous table. So that model was published in 2014. Then in 2019, we published an update of that model 5 years later that had enhanced adjustment for chromosomal abnormalities, syndromes, and non-cardiac congenital anatomic abnormalities. What this model did was took the original set of variables that were in the model and focused on what's in this red box, the non-cardiac congenital anatomic abnormalities and chromosomal abnormalities. So instead of adjusting for the presence or absence of any non-cardiac congenital anatomic abnormality or any chromosomal abnormality, the new model specifically adjusts for the specific abnormality. So this model takes into account the fact that trisomy 18 has a higher risk than trisomy 21. And it takes into account the fact that doing heart surgery on a patient with a congenital diaphragmatic hernia is more risky than doing it on a patient with gastroschisis or intestinal atresia. This is the model that's currently used in the STS database for detailed risk adjustment to augment the stat categories and stat score. I'd like to now move on to how do we know that the data is complete, accurate, true, and believable? Again, Francois pointed out that after we have nomenclature, after we have a database, and after we can risk adjust, we have to make sure that our data is complete, accurate, and true. 3 methodologies exist to do this. Intrinsic data verification is where we look into the database and make sure that the data itself makes sense. So both the STS and the ECHSA-SICCH databases have methodologies that one can go into the database, and if the data says that a neonate weighed 300 kilograms, that's recognized as illogical and that data is eliminated from the database. Similarly, if a patient's date of surgery is 1 year before the date of birth, that's recognized as an error and eliminated. So that's intrinsic data verification. The third point is to use other data sources like national death registries to verify vital status. But the middle point is really the point that where most efforts have been focused most recently, which is the audit process, to audit the data at the site to make sure the data in the database is concordant with the actual data within the hospital's electronic or paper health records. In the United States, David Overman, who's currently the president of the Congenital Heart Surgeon Society, has led an audit initiative of STS data, which was published in the World Journal. 10% of the sites are audited with detailed audits every year in STS, and some of the results of the audit shows that the data in the STS database is highly complete and accurate. The mortality data is 100% complete and 99% accurate. The only mortality variables that are missed are mortality variables that are related to some patients that had PDA ligation and then were sent back to the NICUs at remote hospitals and died months or years later, and we missed those mortalities. But 99% complete, accurate, 99% accuracy on mortality and 100% complete, and the remaining quality of the data is quite good as shown on this slide. And again, importantly, the quality of the mortality data is quite good and gets better and better every year. Now, in Europe, under the leadership of the European Congenital Heart Surgeon Society and Bogdan Marashevsky in collaboration with Claudia Herf, a similar audit initiative took place and was also published in the World Journal of Pediatric and Congenital Heart Surgery. And this audit initiative also documents that the quality of data in the ECHSA database is documented to be complete and accurate through an audit process. This audit process was led by Dijslav Tabata, who has collaborated for over 20 years with Bogdan Marashevsky in Poland looking at database initiatives. So with that background on these 4 areas, I'd like to spend just a few minutes talking about the remaining 4 areas, not going into as much detail. Collaboration between subspecialties is the first area that I'll discuss. And this area, I think, is an area that's ongoing, rapidly developing, and extremely important, because all of us would agree that caring for patients with congenital heart disease is multidisciplinary. A group called the Multi-Societal Database Committee for Pediatric and Congenital Heart Disease began working on multi-societal collaboration for databases with that document outcomes about the congenitally malformed heart back in 2005, and hosted annual meetings from 2005 until 2019. The 2020 and 2021 meetings did not take place because of COVID, and that led to a virtual collaboration with this group. This group published a 530-page supplement in Cardiology in the Young, laying out the principles of collaboration between cardiology, cardiac surgery, anesthesia, and critical care in the database environment. The group led to tremendous collaboration between surgical societies, cardiology societies, electrophysiology societies, anesthesia societies, and critical care societies. The group published rules and strategies for collaboration across societies in the database world. And ultimately, many of these ideas were then incorporated in the development of an organization called Cardiac Networks United, which published this article in Cardiology in the Young, and which is dedicated to sharing information across subspecialties about outcomes and quality in pediatric and congenital cardiac care. I'd also like to acknowledge and point out this paper that was recently published in the World Journal just this summer, also acknowledging and emphasizing the importance of collaboration across subspecialties. Europe is the first continent to create a linkage between the interventional cardiology databases and the surgical databases. This is a huge accomplishment and really doesn't exist anywhere else on the planet right now. This manuscript describes a linkage between the AEPC interventional cardiology data and the ECHSA surgical data. This was done under the leadership of the European Congenital Heart Surgeons Association and the Association of European Pediatric Cardiology. And I think this paper is a description of an academic linkage that's going to transform the science of outcomes analysis in pediatric and congenital cardiac care. A few other important contributions of ECHSA related to this are the machine learning contributions that were developed under the leadership of George Saris in collaboration with Bogdan and a group of scientists at MIT that looked at utilizing machine learning approaches in both this paper and this paper to take the ECHSA database and apply the newest statistical methodologies. And this finally is a paper that also involved tremendous subspecialty collaboration. This was a multi-institutional randomized trial that looked at perioperative steroids, utilizing the STS database as a platform for the randomized trial. And this science was solid enough that it made it into the New England Journal, which was the first STS congenital heart surgery database paper to get into the New England Journal of Medicine. Linking databases. What I just talked about between ECHSA and AEPC is important in the world of linking databases. There's a few ways to link databases. These terms I wanted to introduce. Deterministic matching is when one has the same exact field in both databases, and the patients can be linked based on either the patient's social security number in the United States, or the patient's name, or the patient's national health insurance number. Many databases cannot be linked by a shared direct identifier, and instead algorithms of probabilistic matching can be used, where patients can be matched by shared indirect identifiers. In other words, if we don't know for sure their name, but we know the patient's date of birth, hospital where they had their surgery, and their diagnosis and their gender, we can match their surgery with 99% certainty. So that's matching by indirect identifiers, which is also a very valuable way to link databases to them. We had a pediatric heart surgery grant to link the STS database to an administrative pediatric database called PHYS. This was funded to $2 million by the National Institutes of Health in the United States. This database had two aims: to develop and validate a composite quality metric in pediatric heart surgery that looked at not only mortality, but also morbidity, and then so to look at the relationship of that composite metric to healthcare economics. And to do these aims and accomplish these aims, we had to link together the STS database to a database called the PHYS database. We developed a composite quality metric that utilized both mortality and morbidity, taking data from both of these two linked databases. And the morbidity metric looked at a variety of complications: renal failure, stroke, paralyzed diaphragm, unplanned reoperation. And this was the first multi-domain composite quality metric for pediatric heart surgery. The data was developed from an analysis of 100,000 hospitals, 78,000 operations. The mortality in the group of patients was 3.1%. The length of stay was median of 7 days, but 13.3% had major complications. So this was used to develop a composite metric, and this is just a graph that shows variation in performance on this composite metric, where 1 is the average performance across the database, and the box shows the point estimate of a hospital's performance. The bar is their 95% credible interval, and this graph shows tremendous variation across hospitals via this composite metric that was developed by linking databases. About 16% of the hospitals performed better than expected. About 8% or 9% performed worse than expected. So about 1/4 of the hospital were statistical outliers utilizing this composite metric developed by linking databases. So This information was subsequently used to assess healthcare economics and variations in cost per caring patients across hospitals. And I won't go into that in this presentation, but all of that information has been published. I'd like to briefly talk about the holy grail of longitudinal follow-up, finding out are patients alive, not just at hospital, but discharge, but at 1, 5, and 10 years later. One way to do this is by linking to national death registries. In the United States, we've done this with adult cardiac data, utilizing a couple of national death registries, the Social Security Death Master File and the National Death Index. And by linking STS data to these national death indexes, we're able to confirm longitudinal survival over time. And this work, again, has been published in the Annals of Thoracic Surgery. This shows linking of the STS database to Social Security data to verify longitudinal vital status. This is another publication based on that Social Security linkage. And this links the STS data to governmental health insurance data or Medicare data, also to look at longitudinal outcomes. So there's a variety of ways to get longitudinal data, linking to national death registries like the Social Security Death Master File and the National Death Index, developing global unique identifiers for patients, and implementing longitudinal follow-up modules within the registries. STS is currently exploring, in collaboration with CHSS, tools to do longitudinal follow-up in greater detail within the STS database. And my last point, all of this is used to improve quality. So how do we define quality? I think, when I started doing these database talks, my daughter looked up the definition of quality in the dictionary. And quality, according to the Webster Dictionary, is just how good or bad something is. And we want to use our database to document how good or how bad of a job we're doing taking care of our patients. Donna Bedian described quality as having 3 domains: structure, process, and outcome. All 3 of those domains are captured in our databases. And Michael Porter defined value as the quality divided by cost. So if we can measure quality and then find how much it costs to get that quality, we can then determine the value of the healthcare that we deliver. So what I've tried to do is quickly go through all of these 8 points in a quick 30-minute presentation. The reason that we do all of this work is because science tells us what we can do, guidelines tell us what we should do, registries tell us what we're actually doing. And if we use our databases, we can learn what we're actually doing, and we can figure out how to do it better. Another way to say it, and this is one of my favorite quotes, is without data, you just have an opinion. You don't have any facts. Data is the true power. Again, we've covered the domains of outcomes, quality, safety, and research in this talk. I'd like to finish by acknowledging the European Society, the European Association of Cardiothoracic Surgery, and the European Congenital Heart Surgeons Association for their support of the recent World Congress of Pediatric and Congenital Heart Surgery, which was held in Washington, D.C. and attended by 5,752 people. There was a number of surgical societies that collaborated, and under the leadership of Vladimir Ovita, ECHSA played a major role in this meeting, chaired some sessions, and had a very important presence. I'd like to again acknowledge the group in Italy, their past chief, Giovanni, who's a dear friend of mine and my family's, and their current leadership under Vladimiro. We've had the pleasure of hosting Claudia from this group at our institution over the summer. Claudia is a rising superstar, and we look forward to having her come back and spend more time with us, hopefully in about a year and a half. And finally, I'd like to move on from the meeting we just had to the next important meeting we are going to have. The World Society of Pediatric and Congenital Heart Surgery, in collaboration with ECHSA, is hosting this meeting in June 2024 in Bologna. The local host and chair of this meeting is Vladimir Ovita, the president of ECHSA. This is going to be a great meeting. I love coming to Italy. My family loves Italy, and we're all going to be there. This meeting is dedicated to Juan Carlo Rastelli, of Italian descent, who made tremendous contributions at the Mayo Clinic. The meeting is hosted by a number of organizations, including ECHSA, CHSS, and the World Society. And there's a number of other organizations that are participating, including, importantly, the Italian Society. And I look forward to visiting Italy with my family and participating in this wonderful meeting that Vladimiro is leading. And with that, I'm happy to take any questions. And I hope I didn't talk for too long. I tried to keep this to about 30 minutes.
Thank you very much, Jeff. Outstanding presentation, very outstanding.
Thank you.
Well, yeah, we have 10 minutes because at 8 o'clock you have to go to the ICU, right?
Correct.
Okay. So is there any question from the audience?
I think they can raise their hand if they have questions, or write in the chat. If they raise their hand, I can activate the audio if someone wants to talk from the audience.
Jeff, well, this is a clear, demonstration about the power of databases, the power of data, and their impact in our clinical practice. Does this quality analysis evaluation applies to all countries around the world? How can you apply to low-income countries or countries with limited resources, where the outcome are more related to other facts and other confounding factors?
Yeah, I think this is a great question. I think the science of measuring outcomes and trying to do better at what we do every day applies universally, whether one is in a low-income country, a middle-income country, or a high-income country. But the way that science is applied is going to be very different based on the available resources within that country. I can give an example on a personal note. I know the number of people who work on entering data and doing database science at the University of Florida, where I operate. Alternatively, I spend 2 weeks every year operating in Jamaica. In Jamaica, we maintain a database that keeps track of all of our patients. There's no full-time employees that work purely on the database like there are here at the University of Florida. There's not the detailed level of risk adjustment and risk modeling like the STS database does, but we have a database. We keep track of all of the operations that we do. We review that information, and we try to learn about where we can do better and what are our opportunities for improvement, and also where we're doing good and where we can learn from what we're doing good. So I think maintaining a database of the operations and looking at those operations and learning from them is an act that can be done anywhere, whether it's in a high-income country or a low-income country. But I think the details of the science will vary based on the economic background of the country. A simple Excel spreadsheet keeping track of all the operations is an inexpensive way to do it that can have tremendous value. And I would think that any low-income country should be able to, at the minimum, keep a list of all the operations and try to learn from that list. I know that that's what we do in Jamaica. It works quite well. So the answer to your question is it applies to all countries, but the way it is applied varies based on the economic situation of the country.
All right, thanks so much. Alvise?
Well, Jeff, I'm honestly and genuinely impressed by how you manage, data, and how you manage actually the interpretation of data.
Thank you.
I honestly, I'm not. I still think that there is not. It's still uncommon among cardiac surgeons around the globe, and when I spend some time, sometimes of my training in Toronto, there was this important fellowship that is called the Kirkland-Osborne Fellowship. There are a lot of residents here in our audience from Italy, and they may not even know that this fellowship exists. And this is mainly to teach the new generation of cardiac surgeons how to analyze data, how to interpret data, and how to do statistical analysis. So during my career, I was lucky enough to find people that taught me these aspects, but maybe in Europe we still lack this particular aspect. So maybe ECHSA and ECHSA-SICCH should a little bit work on this. I just wanted your opinion on this, the importance of this aspect, because a lot of residents are always focused on the surgical aspect, like moving their hands, but then there's all this chapter.
Yeah, I think this is an important chapter, and I think you're raising a very good point. The Kirkland-Ashburn Fellowship is a very special position. Obviously, it's named after Dr. Kirkland, the father of the current president of the World Society of Pediatric and Congenital Heart Surgery. It's named after his father, James Kirkland, who was one of the founding fathers of pediatric and heart surgery in general. And then David Ashburn was actually the first Kirkland Fellow. and it's a tragic story. He was the first Kirkland Fellow. He completed his fellowship, wrote papers, went back and finished his training. And in the last month of his training, with a wife, with children, about to start his new job, he was out getting a heart on an organ procurement, and the airplane that he was on crashed in Lake Michigan, one of the Great Lakes, and the entire procurement team died. And I knew David Ashburn quite well from his fellowship days. He was a great man, and it's a tragedy. And that's when the fellowship became the Kirkland Ashburn Fellowship. This fellowship has trained a number of world-class data scientists. Tara Karamlu, for example, who is now an attending at the Cleveland Clinic. Anusha, who is an attending at Great Ormond Street, David Hickey, all of these people went through this fellowship and now are practicing surgeons who have tremendous expertise in statistics. I honestly don't have that expertise in statistics myself, and I love working with these brilliant people. I'm good at getting the right people in the room together, but these people who have had formal training in statistics under the leadership of Eugene Blackstone, they're able to bring a level of science to the work we do in the database that's truly stunning. And I think investing energy and time in teaching new surgeons the science developed by Eugene Blackstone has tremendous advantage for the future. And any strategies that we can implement both in Europe and North America to train the next generation in this area of science has tremendous value. It's certainly valuable to have somebody spend a year studying this type of science under the leadership of Dr. Blackstone at the CHSS. Similarly, it's valuable to have somebody spend a month of time studying this in collaboration with people who know this. It'll alter their entire career, and ultimately it'll make all of us better at taking care of patients.
Thanks a lot.
Thanks.
I think Jürgen wanted to ask something.
Yeah, thank you, Jeff, for this great talk. It's a very, very interesting overview of all that big work you did for the last 20 years. It's a very significant contribution and helps us so much in our daily practice. So thank you very much. I have one simple question. Usually we are reporting and analyzing procedure-related outcomes, but not every baby is operated because of multiple prior complications and so on. And my question is, when do we come to analyze diagnosis-related outcome, and at what time point do we include this diagnosis? Is this prenatally, or is this just prior to the operation? What do you think?
I think the diagnostic information is of extreme value in this research. I know that currently the ECHSA database and the STS database both capture diagnosis, and we capture the diagnosis at any given operation. And we also capture the patient's fundamental diagnosis, which is the diagnosis that they were born with. So that diagnostic information is of extreme importance, and we capture it. We need to learn to use it better. And John Meyer has done some important work about linking diagnoses with procedures to enhance our ability to analyze outcomes. But the other part of the question that you're raising is, what about patients who don't have surgery, and how do we get them into our databases? Many CHSS cohorts are what we call inception cohorts, and include any patient with the diagnosis, whether or not they were operated. The problem is capturing the non-operated patients has always been a little bit challenging. I think the collaboration we've recently initiated with the AEPC, linking the interventional cardiology module to the surgical database, is a step in that direction, because now our database will include patients who don't have surgery but have transcatheter interventions. And that, I think, maybe is the first step towards eventually getting all the patients with the diagnosis, regardless of whether they had medical treatment, transcatheter treatment, or surgical treatment, which ultimately should be our goal. And I guess I'd summarize this whole part of the discussion by saying this is where collaboration is important, and this is where collaboration within Europe between ECHSA and AEPC is leading the way, and I think pointing towards how to go in the future.
Thank you.
So Jeff, we have a question from
Jürgen. Yeah, Jürgen, it's good to see you, and I'm really sorry I cannot be at the EACTS meeting this year. It's just an issue of call and coverage and being out of town too much.
That's okay. That's a pity. Next time.
I will be there next year. I love the EACTS meeting, and next year I will be there.
We have a question from Giovanni Stellin.
Hi, Jeff.
Giovanni, it's so good to see you. I was hoping you would be on this Zoom. I didn't know for sure, though.
Okay, let me say a few things. Awesome, as you used to say. Well, I would like to echo everybody, acknowledgement for your lecture. Outstanding. In addition to that, I did witness the last 25 years so much work you've done in order to put the two continents together, the United States and Europe together, and the rest of the world. And in addition, I witnessed all the work that you've done with Bob Anderson, Richard Van Praag, and in a database, which was really outstanding. So I think your contribution for our specialty in the last 25 years has been really immense. And I hope it's going to be even more in the last, how many decades? I don't know. You're going to be working with us. So again, Jeff, outstanding. You're my greatest friend, and I would like again to acknowledge what you've done with Dr. Marczewski, with Krzysztof Chervenkov, in putting the two continents together across the Atlantic. Your work has been outstanding, will be a knowledge for all our lives.
Well, Giovanni, thank you so much. I hope that you like the picture I showed of you with the fish. That was one of my favorite days in my life.
As a matter of fact, I took a screenshot because I didn't have it. So I will show it to my friends who are fishermen, who are catching a lot of big fishes, and say, look, I've done that too.
Yeah, in Florida. In Florida. I would point out that, Giovanni, you're one of my heroes and one of my mentors throughout my life. And you've taught me how to apply leadership within the world of surgery. And you were my friend and my supporter, both through the good times and the challenging and bad times in my career. And I'll never forget that. You are a good man and somebody that me and my family think the world of. And thank you for everything.
Thank you, Jeff, for these very nice words. Indeed, I'm looking forward to see you in Bologna next year and share more time with you. And you know what? Take your running shoes.
That's right, man. For those of you who don't know, Giovanni and I have gone running together in 5 continents. And it's amazing. I love it. I love it. I will bring my running shoes, and my wife is looking forward to seeing Stella as well.
Absolutely. Okay, Jeff. Thanks a lot for acknowledging what my little contribution, but you have done really a hell of a lot of work that has to continue to be acknowledged all over our specialty.
Okay, I think Jeff, you have to go now.
Yeah,
so thank you very much for your time. Thank you very much for sharing your experience and knowledge on this subject with us. This is a great first lecture, and we are very great to you and hope to see you very soon, but maybe first in Bologna and then later on afterward. So thank you very much, Jeff. Thank you very much to all the audience. We're going to see each other next month with the following Journal Club and the next international lecture. Thanks so much, and goodbye. Have a nice day.
Thank you very much.
Vladimiro. Thank you,
Bye-bye.
Vladimiro. And thank you, Alvise. You've done a great job. Congratulations. I'm proud of you.
Thanks.